Welcome to Raaonline. Today we will see about ventricular septal defect. It is the second most common congenital cardiac anomaly, second only to bicuspid aortic valve. Earlier it was reported as much as 2.5 per thousand live births. Now because of easy availability of echocardiogram in testing of children, it is reported as high as 5 to 50 per thousand live births. So VSD is a result of the delayed closure of the interventricular septum beyond 7 weeks of intrauterine life. It can occur in isolation, which is common in 20 to 30% of patients with VSD, or it can be associated with other cardiac anomalies in about 50% of cases. Other cardiac anomalies associated can be either acyanotic or cyanotic heart diseases. Acyanotic associations are ASD, PDA, right aortic arch, CoA and pulmonary stenosis without TOF, while cyanotic heart disease can be TOF, truncus arteriosus, TGA, DORV and AV canal defect, also called as endocardial cushion defects. So other syndromes associated with VSD are common syndrome is trisomy 21, also called as Down syndrome. Down syndrome is very common, but the association of VSD in Down syndrome is only 50%. While Edwards syndrome, which is a very uncommon syndrome, it has 100% association with VSD. Other syndromes are trisomy 13, Patau syndrome, deletion Q21, which is also 22q11, deletion 22q11, also called as Dijard syndrome or catch-22. That is also 50% of catch-22 syndromes are associated with VSD and other complex cyanotic diseases like truncus and interrupted aortic arch. Other associations are deletion of 4q5p 2132 and other aneuploid syndromes like GATA4 mutation, NKX 2.5 or TBX2 are associated with VSD. In history of VSD, there are two important names to remember. One is Henry Roger. He is a French pediatrician. In 1879, he described a small or restrictive VSD which is asymptomatic. He found a murmur in asymptomatic children and he described the VSD as a simple non-cyanotic communication between the two ventricles which is compatible with the life and exercise, which is not associated with pulmonary stenosis, and it has a characteristic whirring pansystolic murmur which is loud not at the apex but at the sternal border and associated with a purring thrill. He described this typically which is a small non-cyanotic asymptomatic restrictive VSD, and since he is the first one to describe classically this VSD, this congenital asymptomatic small or restrictive VSD is called by his name, called Malady D. Roger, and the murmur he found, that is a loud pansystolic murmur which is harsh and present in the sternal border, is called the Roger's murmur or Bruy D. Roger. And the second historian is Eisenmenger. In 1898 he described a cluster of cases who had congenital heart disease but who progressed to develop cyanosis later at beyond 20 years of age. It is a patient with a VSD with pulmonary hypertension and cyanosis. This is a characteristic complex called Eisenmenger complex. Later Eisenmengerism, that is reversal of the shunt with the right to left shunt, is described in other acyanotic diseases like ASD and PDA. Those syndromes are called Eisenmenger syndrome, while VSD with Eisenmenger is called Eisenmenger complex.